The development of baro-endoscopy-assisted endoscopic retrograde cholangiography has allowed the endoscopic treatment of a biliary anastomotic stricture in patients with surgical altered anatomy. However, challenging cases have remained. EUS-guided biliary drainage (EUS-BD) has emerged as an alternative procedure to percutaneous transhepatic biliary drainage (PTBD) for failed ERCP. On the other hand, the new digital per-oral cholangioscope (DPCS) spyglass DS system has also been developed with marked improvements in terms of the image quality and system setup. This video shows antegrader therapy using this new DPCS through the EUS-guided hepaticogastrostomy (EUS-HGS) route for restriction of the biliojejunal anastomotic site. The patient was a 77-year-old man who underwent Whipple surgery for pancreatic cancer 7 months ago. He presented with jaundice and abdominal pain without fever. Laboratory tests revealed hyperbilirubinemia and elevated hepatobiliary enzymes. Abdominal CT showed dilated bilateral intrahepatic bile ducts and the biliary anastomotic site stricture. Partially double balloon endoscopy-assisted ERCP was performed, but it failed owing to the non-visible anastomotic site. EUS-HGS was performed using a 90-gauge needle, and attempts were made to pass a guide wire antegrade through the EUS-HGS route, but it failed. Thus, an 8 French plastic tent was placed from the stomach into the intrahepatic bile duct for biliary decompression. 1 month later, we reattempted to make an antegrade guide wire pass into the stricture of the anastomosis. However, this was still not possible. Therefore, because of this failure, we achieved detection using the new DPCS through the EUS-HGS route, and a 10 French plastic stent was placed for dilation of the EUS-HGS route to allow DPCS smooth insertion. After 1 week, a catheter for cholangiography was inserted through the EUS-HGS route. The DPCS was then inserted over the guide wire through the EUS-HGS route into the distal end of the biliary duct. Eventually, the anastomotic site could be detected as a pinhole, and an 0.25-inch guide wire could pass through the stricture. Then, a saw-handle stent retriever catheter was inserted for the dilation of the stricture. Subsequently, a 15 mm balloon dilation catheter was gradually inflated. Finally, an 8 French plastic stent could be placed from the stomach to the jejunum through the anastomotic site. During this procedure, there were no adverse events. In conclusion, the new DPCS with good visualization through the EUS-HGS route could detect a severe stricture of the biliojejunal anastomotic site, and antegrade dilation and stent placement were successful. A series of these therapies may be considered as an alternative therapy in selected patients with a severe stricture of biliojejunal anastomotic site.